Hello, everyone that's coming in. We're going to get started right at 11:15. Okay, by my clock, it is 11:15, so we're going to go ahead and get started. Welcome, everyone. Thank you for joining this session, Harm Reduction, Establishing, Implementing, and Innovating. We're really happy to have you, and just a few housekeeping items before we get started. This session is being recorded and it will be available about an hour after the presentation closes. Please keep yourself muted unless one of the presenters asks otherwise. And we will be leaving 5 minutes at the end of the session for questions. So the presenters will be opening up and you can open up your mic and ask whatever you like. Or if you'd like to go ahead and put your questions in the chat, that would work too. The conference is also offering free continuing education credits, so you can go ahead and visit the continuing education page for more information on that. So with that, I'd like to introduce our three presenters. Seth Dewey has been actively involved in the recovery community in the area, especially in the recovery housing area since 2017, and in 2019 was elected to the Oxford House Ward Council, where he currently serves as the vice chairman. In January of 2020, he was brought on to the Reno County Health Department in the role of substance misuse health educator, where he serves as a project coordinator for substance misuse grants from the state and federal government. Seth is also a founding member of the Kansas Recovery Network, Addicts Against Overdose, who in October of this year received their 501c3 status confirmation from the IRS. Seth is currently pursuing his bachelor's in science in organizational leadership through Fort Hays State University, where he also serves as a student senator and serves on the Equity and Inclusion Committee. We also have Anna Woodburn as a person who has a lot of experience working with disenfranchised groups, and is very important to her to bring a strengths-based approach along with harm reduction principles into every area possible. She has several years experience working with those suffering from substance use disorders. She currently works in health education and as a board member for the Kansas Recovery Network. She is passionate about fostering real change to help real people. Jackie Espinoza is a former addiction treatment professional, a person in long-term recovery working to end stigma, enable breathing, and reduce harm in rural Kansas. And so with that, I'd like to turn it over to Seth to get this presentation going.
Right. So like she said, that's who we are. We're the Kansas Recovery Network. And actually, I'm going to turn it over to Jackie to get us going on this.
Okay, so I'm just going to go over real quick the basics of what harm reduction is. Harm Reduction 101, a crash course, if you want to go next. So the definition of harm reduction is that it's a set of practical strategies and ideas aimed at reducing negative consequences associated with drug use and other human behavior. So we see harm reduction in daily life all the time. Sunscreen protects us from the sun, obviously. Seatbelts and speed limits protect us from motor vehicle accidents. Birth control and cigarette filters protect us from some of the riskier behaviors that humans participate in. Vaccines are also a really well-known harm reduction type of a thing. Next. So this shows the way that harm reduction and prevention kind of work together. So the primary purpose of prevention is obviously to prevent the initial use or delay the initial use of substances. Their secondary objective is the early detection of or reduction of substance use once problems have already begun. And when prevention gets to that secondary point, that's kind of where harm reduction steps in. The last leg of that is reducing substance use problems or harms to prevent further deterioration or death. And that's kind of just showing you how the two work together. So harm reduction with substance use. Hopefully everyone on this call has heard of naloxone and Narcan. It reverses the effects of an opiate overdose. It's not a guarantee, it's just a chance. Syringe exchange and those programs we don't have here in the state of Kansas because it's still illegal to possess a syringe at this point, but they reduce the spread of bloodborne infections like HIV and hepatitis C. And I kind of did a non-official survey. I asked over 100 drug addicts if they had ever been diagnosed with either of those infections, and 1 in 5 had. So it's definitely a real life problem here in Kansas. And now I'm going to give it over to Seth.
Actually, we're going to turn it over to Anna.
Hi, my name's Anna. So, just to kind of start out, we're going to talk about how we kind of began establishing. We really didn't start out with the idea of being a harm reduction organization or coalition. Essentially, we had a lot of people dying, particularly in our area. A lot of us, were really well aware of how overdoses had been on the rise for several years. There was a particular time, in 2018 where we really had a lot of our friends dying and without a lot of validation of what exactly was happening. Very often we don't know what someone died of until the toxicology report comes back, and then we may or may not know about it. We had some differences of opinion within public leaders about how to classify particular deaths, but we knew our friends were were dying, and we felt very called to do something about that. So if you want, I think you can go to the next one if you want. So kind of it started out for the most part with just Oxford House alumni within Reno County wanting to begin doing like education within the community and with people, particularly in recovery, because as we know, if you are abstinent from substances, a return to using leaves you really susceptible to an overdose. And although we were having fentanyl, obviously in substances at that time, it wasn't even as prevalent as now, as it is now in Reno County, particularly, or in Kansas, particularly. So one of the first things we did was do an event, an education and awareness event at one of the Oxford houses, which included help from the Reno County Drug Court, a prevention network in Reno County, the Drug Impact Task Force, really all collaborated to pull off this event, which we really had pamphlets and information, a speaker to explain how to spot an overdose, how to respond to an overdose, how to use naloxone should you have it. We had a lot of the things mentioned in the prior presentation about harm reduction, like the doTERRA bags. We had pill caps that had a little timer on the top for, elderly people maybe that forgot how recently they took their medication. And so it would show you how many hours it had been to help prevent those kinds of overdoses. And for those who don't know, Oxford House is recovery housing where people, inmates run the asylum. So, people like us go and live in these houses and manage and maintain them, and then have continued to contribute to their communities around them in various ways. We can go to the next one. So we had, after that event, we had a member overdose in an Oxford house in Reno County. The person did survive that overdose, but it left a lot of people really, really shaken up. It was getting closer and closer to home at that point. And so I found the statute on being able to have naloxone and figuring out that, we are a standing order state. And so you don't necessarily need a prescription to go to your pharmacy to request naloxone. So I started calling pharmacies because, we had I don't know, I think 10 houses, maybe including Great Bend at that time, that we were trying to figure out how to supply them with Narcan. And I called all the pharmacies in Hutchinson, and some of them didn't have it. Some of them told me, we have, one box that's $140. I called Walgreens and I said, do you have it? And she put me on hold. And then she came back and said, yeah, we can, we have it, or we can order it. And I was like, well, I need like 10. And she was like, let me put you on hold again. And so it's just kind of an example of the difficulty of accessing naloxone, or the education or understanding of how to get it. So that was really important to us to figure out. So I actually got a hold of somebody from a harm reduction organization in another state, and he shipped us enough Narcan for each house to have one, which kind of began Oxford House, training every single member on how to spot an overdose and how to use Narcan or naloxone. And every week they have a business meeting where they put in the minutes where the naloxone is, and what the expiration date is on it every week, because then everybody knows. And so, just thinking of, I couldn't tell you a number, but just thinking of every single person that's probably been in Oxford House in Reno County since 2018, every one of them has been trained on how to use Narcan, which is really a big deal. We currently have 10 houses in Reno County, and we'll say average of 10 person per house. And as we all know, with recovery, sometimes there's some turnover. So really every new member gets trained, and that's really cool. Seth is going to kind of talk about some of the next steps we had.
All right, thank you, Anna and Jackie. So yeah, like Anna said, it was one of those things that I don't think anybody knew in the middle of it what was happening. We just knew, like Anna said, that our friends were dying and people like us were losing their lives. And so we felt like we needed to do a little more. And fortunately, Anna and some of those alumni were there right at the start of my personal journey of recovery. And what that did for me and giving me purpose was just absolutely instrumental. But in particular, the summer of 2018 was a really, really hard one. We lost several of members of, at some point, the recovery community, the Oxford community, in just a few months. We lost 5 of them in a few months. There were many more overdoses that year in Reno County, but those are the ones that really seemed to impact us at this time. And what we wanted to do was we wanted a voice. We heard so much about the opioid crisis. We heard so much about end overdose, and we wanted to do more. So we brought it to those respective organizations like that Anna mentioned that helped us out with that other event. And we decided we were going to have a remembrance or awareness march. Now, at first, I will admit, when we brought this to the community, they wanted to wait. They wanted us to wait until we knew for sure if these were all official overdose deaths and things like that. But we had the family members coming to us. We had the family members encouraging us to put on these events. So we did that, and you can see those pictures there in this slide where we had about 200 to 300 people that marched down the street all the way to Avenue A Park in Hutchinson, Kansas. And what was really cool was that we had people from all over. We had the faith-based community, we had law enforcement, we had community corrections, people in recovery, the families. It was amazing. And when we got to the end of that march to Avenue A Park, that's where we had our calls to action. We went through Narcan education. We talked about the need for widespread trainings, easier availability, and more recovery resources. And then we gave a safe space for the families and for those in recovery to tell their stories. Now, this couldn't have happened without the widespread community involvement and the support from multi-sector partnerships. But I will say that it started, like most things, with a grassroots movement. So now we're going to go into some of the implementation of some of the things and how it's grown from Anna doing those events in front of an Oxford house in Hutchinson, Kansas, and from small conversations in rooms. And we're going to get into that now. So at this point, we were the only ones in our area that were providing Narcan, that were going through signs of an overdose and things like that. And we knew that if we were going to continue this pace with the price of naloxone and also with the lack of resources at the time, that we needed to organize and we needed to reach out. And so that's what we started doing. Some of those things you can see in the pictures. We held trainings. We also held fundraising events. We made shirts and things like that to support the cause. And we did consistent content on social media, especially Jackie and Anna. They are constantly pumping out some really good evidence-based information about harm reduction and continually helping to bring about the cultural shift that we're trying to bring about with this message of harm reduction. So something that had been going on for a while, actually since 2015 in Reno County, there was a group called the Reno County Drug Impact Task Force. Now, that group met and started in 2015, like I said, because of overdoses back then that were happening. And since then, it's became the Reno Recovery Collaborative. And there's been a great partnership with that collaborative and the health department. And in January of 2020, they brought on a person in recovery to manage substance misuse grants. And that is actually me. So I'm super blessed and honored to be able to have that position. I never thought that a person in recovery with some of the past that I have would be able to work in a position like this. We did change the name, the Drug Impact Task Force, to the Reno Recovery Collaborative to make it sound more like it is, right? The county changed that to that name to bring about more people, to get rid of the sort of the law enforcement feel to it and encourage more involvement. And when that happened, KRN, or the Kansas Recovery Network at the time, Addicts Against Overdose, was brought to the table even more so in more of a capacity, along with others in recovery. Something else that happened in Reno County is they started tracking overdoses in real time, increasing the ability for us to coordinate with those of us in Kansas Recovery Network a more rapid response. They also included Kansas Recovery Network on a new form of public messaging for press releases related to new and emergent drug trends and spikes in overdoses. And we'll get into that a little bit more. Kansas Recovery Network was even added to the Hutchinson Police Department's approved policy for ones that could be, that might be at the scene of an overdose. And I can't give enough appreciation, enough shout out to Chief Hooper for, and the Hutchinson Police Department for recognizing that and for continuing to help us out in our endeavors as well. Now, Kansas Recovery Network continued training local businesses and other community partner agencies, including some of those businesses included the hotels in certain parts of town that were more prone to more events, and also the several bondsmen specifically were reaching out to have this available to them. And then most recently, the Reno County Sheriff's Department and the Hutchinson Police Department all now have a policy to carry naloxone or Narcan on them. We can thank DECA for their efforts in helping us break that barrier and get them that training as well. So we see once again this this collaboration. You know, we all are faced, no matter what field we're in or what capacity, we know that substance use disorder and the associated issues that come along with it are all adaptive challenges. Meaning that not only do we know the cause all the time, it also means we definitely don't always know the solutions, right? And so it's so important for us to collaborate. Collaborative leadership is the way we can truly fight these adaptive challenges and face them. So the collaboration began with community partners, and it's been instrumental in us having the community understand what we're doing, but also having the buy-in, the support. And we'll get into some of that support later on too. I get so excited, I want to cover too much. And also realizing that substance misuse is a public health issue. So having that strong relationship with local and state health departments is super, super important as well. Unfortunately, we've been able to foster that and been able to keep it. We've had several times where the members of the Kansas Recovery Network have met with public officials, been interviewed with various media outlets, shared needs, plans, distribution dates on all those things. We've been featured, most recently, Jackie was featured on a podcast by Representative Jason Probst, giving more of her personal story, but also leading into that harm reduction message that comes about most times when we're talking about these issues anymore. So that's something to note. So one of the things too that we mentioned earlier was the improved tracking of overdoses with community partners. So how that really went into it or fits in is when we started utilizing, or when the Reno County started utilizing the program OD MAP, a public dashboard was made. And this is it right here. Granted, this was a while ago. It's obviously changed since then. I should have updated that. But so you can see here not only the amount of overdoses, but the amount of naloxone administrations and fatalities. Now, our partnership with the health department also allows us to be privy to certain other information, including, which isn't shown on here, the areas where there are higher intensity amounts of overdoses. And that helps us to coordinate some of those responses and how we would go about that. But what's nice about this too is it allows us to look at the substances and having those trends, because a lot of times harm reduction is thought of as right now what we're talking about, particularly with naloxone and things like that. Of course, opioid, but now that we're seeing upward trends of methamphetamine use and stimulant use and polysubstance use, it puts the responsibility upon us to educate. So when we see these trends going, it's time for us to dig out the books, look at the peer-reviewed articles, look at the best practices, and see how we can educate our community with other ways that we can be of assistance to people who are using drugs. So one of the other things that I mentioned, how Kansas Recovery Network is included upon the press releases from the Reno Recovery Collaborative. We had to get adaptive, right? When we noticed certain trends, disturbing trends, the health department staff gets together and they've set an amount of overdoses within a certain period of time that will make us gather together and see if a press release is deemed necessary. For instance, this one was on October 11th, and there were an increase in methamphetamine overdoses, but also letting the public know that there was an increase in heroin overdoses. And if you look at that, we've leaned, even the county has leaned towards that harm reduction messaging of in the next steps, so to speak. There, right here it says, I know it's small, the Reno Recovery Collaborative recommends the following steps and strategies for our community. Naloxone education, training, and availability. There we put DECA, of course, in that resource. Encourage more people to carry naloxone. Encourage members of our community who use substances to never use alone, and to check in on friends or family regularly that are using substances. And then, of course, we have resources for treatment. So this is a way for us to take more of a well-rounded approach to keeping people alive, keeping our community aware, and being transparent. And then also how communities can to get their loved ones the help that they need, and also so families can know in a situation where it's already hard to know what to do, at least here, they know some very basics, how to keep their loved ones alive. And now I'm going to turn it back over to Anna.
Thanks, Seth. So some examples of harm reduction supplies, some of which we use and we distribute, and others are a little more complicated. Legal in Kansas is naloxone or Narcan. It's an overdose reversal medication. This can save a life if used in response to an overdose, along with rescue breathing and medical care. Wound care kits are something we provide. In other states, they kind of have safe use kits, safe using kits, where they provide, even tourniquets, cookers for substances and things like that. Our biggest struggle here is that we don't want to supply the people we're trying to help with items which could get them in legal trouble should they get stopped later on. So we have to be really careful about that. So our wound care kits, of course, help prevent infection, which is, a lot of these things we talk about. I think people struggle with the idea because they think, oh, there's these people that maybe aren't contributing to society, or they're choosing to use drugs, or they're, all these things. But the fact is that implementing these harm reduction strategies actually do make sense for the community and fiscally. So, if you're preventing people from going to the hospital with, abscesses in under their skin by just simply providing them antibiotic ointment, bandages, sterile water, things like that, really help everyone. Condoms, we'll give out pretty much anything that we can that we think can help people reduce harm when they're kind of in a high risk situation. Things that aren't legal in Kansas technically is the fentanyl test strips, which they're actually manufactured to test for the presence of fentanyl within urine, but they can be used to test substances. But it could be considered paraphernalia if found alongside other substances, even though it is for urinalysis. Part of the issue is, maybe someone could beat that in court, right? But getting to that place as a person who's maybe homeless or doesn't have resources is not very realistic. And then, of course, syringe disposal or exchange reduces, communicable disease spread in Kansas. There was, in partnership with the health department, like Seth was talking about, they were able to, with the recent Hep A outbreak, they were able to definitively say that I believe like 70% of those Hep A cases were attributed to IV drug use. So having the capability for someone to not only get new clean syringes, but also dispose of used syringes appropriately, really obviously helps with the spread of disease, but also the issue of people finding them, in their yard or the side of the road, in their dumpster, things like that. You know, we're not saying that there's, you know, that it's acceptable in any sense of the word, but the fact is that even for people who have diabetes, it's really complicated for them to be able to dispose of their syringes. So this isn't just a person who uses drugs issue. This is, you know, kind of an everybody who may need to use a syringe issue. I think you can go to the next one. So, you know, as Seth kind of mentioned with the training to different, you know, businesses and high risk areas such as, you know, Oxford houses, because, you know, if someone relapses while staying in an Oxford house, they're really at risk when they leave. Gas stations, motels, and other businesses like the library, for instance, where you have people that are hanging out for a part of their day. We realize that people who use drugs are most likely to respond to an overdose. So while it's really beneficial to have it kind of everywhere and everybody has it, and maybe, you know, you get trained on CPR and also naloxone in responding to an overdose, it may not seem as prevalent in, you know, in more rural areas as it may be in more metro areas. However, you know, we're still averaging, I think, at least one overdose a day that's reported in Reno County alone. So yeah, we want it everywhere, but the people that are around other people who are using drugs are most likely to respond. So we created a centralized website that has contact information. It has resources for treatment, mental health providers, for crisis lines, for videos on how to use naloxone, and just really easy access for people. We began getting supplies of intramuscular naloxone donated in a lot greater numbers. So we decided to kind of do the pop-up distributions to increase access to people who use drugs and their family members. We know that a lot of people, you know, may not always feel comfortable hitting up a stranger and asking for, saying they need naloxone. So that's kind of what we started doing. And then we asked local businesses, and then some of them asked us if we would do distributions there. And so we really have relationships with even, you know, smoke shops, vape shops, pharmacies, you know, et cetera. We even had, you know, we had a pharmacy not only reach out and ask us if we would do a distribution there, they posted it on their website and said if for any reason someone would prefer not to use intramuscular naloxone, that if they came to the distribution to get naloxone and they didn't want the IM, then the pharmacy would just provide them with nasal, which I really think is just like evidence of how supportive the community has become over the last couple of years of doing this work. I think you can skip, thank you. So this is just our, you know, one of the pages from our website, which has like, it's pretty rudimentary. I'm not an IT person. So we have safe using information, which is what I kind of hovered over to take this screenshot. We have information about who we are, what services we provide, resources, overdose awareness, SAMHSA's number there. But what we try to do is have it, you know, your landing page is local contact information. And now that we have the KRN 501c3, we will be doing a statewide.org, which we can then add chapters, you know, have this landing page and then have chapters for your area for contact information. But we wanted it really easy for people to call us if they needed us, and for them to look at our website very quickly and know how to respond to an overdose. So, you know, we were even tracking with Google Analytics, and in the month of October, we had 60 users, which may not seem like a lot, but it kind of is for just, you know, a local, you know, website that just one of us who has no experience created. So I think you can, yeah. So here's just some pictures, which we really have a lot of cool ones of like us getting prepared for the distributions or being at the distributions. All of our naloxone kits have 2 doses of naloxone, have instructions on how to use it, they also have our cards, which has a QR link, which goes to our website so that people can easily look at how to use the naloxone should they need it. We explain it to them how to use it when they come up as well. You know, the little things in the little purple bags, which kind of look like drug bags, but, you know, we're working with what we can get. Those are the wound care kits that have, you know, bandages, antibiotic ointment, alcohol wipes, and instructions on how to care for wounds and how to, you know, safely inject. And then, you know, in the picture on the far right, there's even some hygiene kits. We've had a lot of people donate, or we've purchased things so we can give out, you know, toothbrushes or, you know, pads, tampons, just whatever. So this isn't an exact number. We've even had distribution since creating this slide, but we have given out around 2,500 doses of naloxone from just May of this year, you know, which is quite a bit. I think you can skip. So some of the distributions we have done have predominantly been in Reno County, but Rice County, Sedgwick County, and McPherson County. I think my notes are a little messed up, but I think that our first distribution that we did, that a pop-up distribution like this, we gave out 334 doses, and this was at a location where people were simply pulling up to get naloxone from us. And our second one, which was just 7 days later, we gave out another 300 doses. So that was really big. We took a while to build street cred, if you will, around the area, but we haven't really had any issues with anybody. You know, no law enforcement hanging around trying to bust people or anything. You know, we have a good relationship with them, and so they're understanding of what we're trying to do. And so when someone does pull up, we essentially just say, hey, how many kits do you need? Instead of trying to make it really weird or awkward, they tell us maybe how many, or they ask how many doses there are, and we explain that to them. We ask them if they need additional things, like, you know, the wound care kits, etc. And it's just not weird. We're non-judgmental. We're very compassionate. We're just like, hey, you know, how can we help you? What can we do for you? And so I think that really makes a difference for people in trusting us, because we're not asking your name and address. We're not asking you, you know, really to give us any information. We're just trying to help you. And I think that value of feeling like, you know, people want to help you regardless of your clean status, right, or your recovery status is really, really powerful for people. So kind of onto the innovating part, which is, you know, kind of things that, you know, we have goals towards, or other people can work towards. Jackie's going to cover that stuff. So thanks.
I had to figure out how to unmute myself. Okay, so the first thing that we really wanted to do is to normalize the life-saving measure. We've told people before just to think about it like it's a Band-Aid. You know, you never know when you're going to need it, but when you need it, you need it. And these are just examples of businesses. I don't even think there are businesses here, but in other places where they've put Narcan right next to the fire extinguisher, right next to their first aid kit, just to normalize it. Next. So obviously we've been talking through this whole thing about how syringe exchange programs are very illegal in the state of Kansas. But we made a friend with another harm reduction coalition in the state of Indiana, where they're also very illegal. And she came up with this syringe disposal site. They're secured locked boxes. You can see right there that there's no way to break into them. And it's just a way for people to dispose of their syringes. So we're not finding them like Anna said in playgrounds. The police officers aren't getting called off of their beats to go pick them up when they find them in yards, because that happens a lot. So this is something that hopefully it's our goal someday to maybe have this here. This doesn't work without the cooperation of law enforcement. I mean, if we have police officers arresting everyone at the syringe disposal site because they have syringes, like obviously it's not going to work. But in Indiana, they had theirs open for, I want to say 6 months, and they collected 200 pounds of used syringes that would have ended up who knows where. Another interesting compromise for the syringe exchange program that's not listed here is the accessibility to clean syringes. There's a lot of pharmacies, especially here in Hutchinson, that if you walk into, there's giant signs in there that say no syringes without a prescription. Well, all that's doing is increasing the likelihood of people sharing syringes. It's increasing the likelihood of them sharing their bloodborne diseases. So if we can't do a syringe exchange, I think that it's vital for us to work with our pharmacies and work on maybe relaxing some of those policies, you know, like allowing them to purchase their own supplies for themselves to keep themselves and the community safe. Next. So the non-traditional treatment option, this is another wish of ours. So when you consider the traditional outpatient treatment options, we expect people to be in the action stage, and they're most likely not. They're most likely in pre-contemplation or contemplation, or if you want to be 100% honest with ourselves, they're there because they got in trouble and they'll go to jail if they don't go. Many of those people, they don't have a lot of income, they don't have transportation, they don't have childcare, they're homeless. There's tons of barriers that reduce their ability for them to attend regularly scheduled treatments for a specific time frame. Some people's jobs, if they're lucky enough to have one, they don't like to let them off from 9 to noon, Monday, Wednesday, Friday, for them to go to outpatient treatment. So what do? Well, drop-in treatment groups, there is no expectation of how often you're going to be there. We're not going to call your corrections officer and tell them that you didn't show up. It puts the client in the driver's seat. It lets them be the expert of what their goals are, of what their needs are. And generally these are offered with resource connection that's very super helpful. Like, let's say someone has a drinking problem, but they also have a DUI problem. They've gotten consistent DUIs and they can't seem to not drink and drive, but they're not willing to stop drinking yet. That's just a non-starter for them. How do we get them to stop driving? You know, and with these non-traditional options that doesn't have abstinence as its only measure of success, you allow them to decide, okay, well, maybe I do want to start reducing my drinking. Okay, maybe I'm not ready to quit using altogether, but I really want to stop injecting. And you let them decide, and you start acknowledging those baby steps along the way. Next, I think. Whoa. Okay, harm reduction in schools. So obviously the best outcome for adolescents is for them to never, ever use substances and nicotine. But unfortunately, that's not the reality that we live in. That's never been the reality that we live in. So what happens if you go into a school and you're talking about the dangers of all of these substances, and the only way to make it through is to not do them, and there are kids in the room that have already tried them, or there are kids in the room who know that their parents are doing them. You've already lost all your credibility with those kids because they know that not everyone who does a drug is a bad person, because they're not bad people, and their mom's not a bad person, you know? So if we start utilizing the harm reduction strategies in school to prevent further harm and prevent further use and offer real education, if we start telling kids the truth about drugs and telling them that doing a drug doesn't make you a bad person. And if you find yourself at a party and you happen to smoke marijuana, or you accept a pill that's offered to you because you're a teenager and those things happen, that it's okay, and you're not a terrible person, and you're not going to immediately go to prison, and you can call your mom and you can tell her, because that's what we're taught about alcohol, but that's not what we're taught about drugs. And the focus is to empower young people to make decisions that reduce the risks associated with substance use while accepting that some teens will use them. We are never probably going to get to a point where 100% of the population is 100% abstinent. That's a crazy goal, but that's the only goal we teach. It's the only goal that's allowed. And there is no room for anything else, you know? And there has to be room for something else, because if you put it in a kid's head when they're 9, 10, 11, 12 years old, that doing these things makes you bad, you build in the shame that comes with addiction, and they're going to be less likely to ask for help. They're going to be less likely to come to you and ask questions. And you have to tell them the truth. That's the point. And yes, the truth is that we want them to never use, but there's more to it than that. You have to finish that sentence. Next. Okay, we did so much better on this one than we did the last one, time-wise. So we have lots of time for questions.
Well, I was just going to add, piggyback off Jackie's, because she did so good at like kind of finishing that up. But I'm not sure if any of you guys know, but I know a lot of people whose parents gave them a substance to use as young as 7 or 8 years old. And so not only are we building in that shame, we're losing credibility by saying, if someone has a father, for instance, that drinks every day after work, and sometimes it gets bad and sometimes it doesn't, but he's not in prison, he hasn't lost his job, etc. So saying only the consequences or potential consequences isn't maybe enough information. And at the same time, if a kid who really could not consent to using substances has already used a substance, and you tell them, please, we need you to never do it, they already think that information is not for them. They already think, oh, this doesn't include me because I already tried to vape once. I already smoked weed once or whatever. And so the goal is to just really be inclusive in that area, because we want all kids, we want to reduce harm for all kids if we can. And so just trying to be inclusive in that language. And I think that kids are a lot smarter than we often give them credit for. So can we talk to them about the reward system in the brain? Can we talk to them about brain development and say, listen, if these things get input into your brain while it's still developing, it can make it really difficult for you. It doesn't mean you're doomed. Can we make it more so they can really understand the full scope of what they're doing? Or what the risks are as far as their personal risks, not a consequence, right? Not necessarily like, oh, you might go to juvie, right? Or get kicked out of school, like the personal consequences, the very personal things. Like, are you ready to is 12-year-old you ready to make a potentially lifelong decision for yourself? And so I think it's that, that motivational interviewing, that strengths-based approach, the stages of change, all these things can really be incorporated into prevention in schools, and prevention can include harm reduction.
And something that's important to note, I love that Anna always brings in the strengths-based approach, because that's what we're going to do. Recognizing that people have the power to make goals for themselves, right? Because when I started my journey of recovery, I'll be honest with you that I didn't want to go back to jail, because I was tired of the same old cycle, right? And so fortunately, and that goal was a goal for a while, you know what I mean? It was a little while. And I thought maybe someday I could go back to doing other things, you know what I mean? But fortunately, my perception changed, right? I got into that another stage, right? But I think it's important to note too that what we're talking about on here is that cultural shift that comes with harm reduction. It's a cultural shift. It's a shifting of the mindset. And 2, realizing that, like has been brought out, there's no one answer. There's no one answer for all of these things, right? So it's important for us to keep an open mind in all of this, especially when we go into those meetings where we're talking about collaboration and we're working with community partners. It's like, we got to keep that open mind so that we can come up with solutions and keep people alive so they can reach their goals. There was a question in here. Do you have recommendations for addressing parent concerns surrounding teaching anything other than abstinence to students and children?
So is the question kind of, Alex, is it, are you saying as a school, is there a way to?
Can I talk on this one for a second?
Oh, yeah.
Oh, I'm sorry, my internet's kind of cutting out. But I think that if we did something like Mothers Against Drunk Driving, but flipped it to something else and maybe not necessarily do a Mothers Against or whatever, I think that might be a good way. And we could even do a presentation to the parents, you know, bring in the parents of the school and let's talk about it, start with them and then explain it to them and let them meet other parents that have lost their child, you know? And I think that that would be a really good way. And I'm sorry, Anna, I didn't know you were talking. My internet cut out and I'm sorry.
No, it's totally okay. I think Jackie, you know, has a good point about that. And if the question is, you know, how do we talk to parents about abstinence, education in schools, which can really, you know, cross lines from sex ed to tobacco to substances. And I think the fact is that there are a lot of evidence-based curriculums which have been developed for these topics specifically. And so I know like a lot of Kansas schools participate in like the CTC survey, right? So giving the parents at enrollment options to opt out or to opt in, letting people know at conferences, sending out a newsletter, hey, we're going to be teaching this curriculum, or we're going to be considering this curriculum or piloting this curriculum. And I think that there can really be, you know, it doesn't have to be graphic. I did a talk this summer with kids at Boys and Girls Club, grades 1 through 3. And it was regarding tobacco, substance use, etc. But do you know what I talked to them about? How do we listen to our body? How do we feel when we're making a choice that we know we're not supposed to do? Where do you feel that in your body? And so I talked to them about consent, and it's like, what about siblings that are taking your toys? How does that make you feel? So if we're talking to kids about boundaries, consent, safe choices because they're listening to their own body, their own core values, that's not saying here's meth, here's what it does, here how it interacts, you know, here's the pharmacology of it, which of course, as you get older students, you could. So I think, you know, educators are very creative in how they can really do this with being more informational and still not, you know, graphic or enabling or condoning. And there are, you know, Scholastic teamed up with the National Institute on Drug Abuse, and they have all kinds of lesson plans on, you know, mental health, screen time, nicotine on the brain, marijuana on the brain. And so there's an article, there's student vocabulary lessons, there's all sorts of ways I think that it could be implemented that isn't simply like, listen, don't do drugs or you'll die or go to prison, which a lot of people have started turning away from. But regardless, the general consensus is still, we have to keep these kids from doing drugs. And yeah, we really want to do that. But we also, you know, for the kid, I had a friend that her mother really had her start smoking weed at age 7 to calm her down, get her to leave her alone. Did that 7-year-old really have a chance at having a successful academic career that was drug-free? You know, and so it's just considering ACEs and everything else that everybody's really working on, being trauma-informed and just trying to be less punitive and more proactive instead of reactive, I think.
This is Stephanie Reinhardt, and I had a question. First of all, thank you for the presentation. Seth, you know, anywhere you are, I'm going to be. So I appreciate all of the information you provided today. And you kind of answered my question, Anna, but I was wondering what your reception has been in the Kansas schools. Because, of course, I know I've been to many of your presentations, and you all know that I work in prevention for youth, and I know that there are many different opinions as it relates to what messaging is going to be received, and you know, with the KCTC survey and the opt-in and opt-out and all of that. So I was just curious as to how received you have been across the state in the school district.
So I'm going to chime in real quick about this one. So I noticed that with one of the things that I've noticed is as long as we stay, it's kind of like all the information we've learned in the last 2 years about humility, right? And realizing, I know for me, the biggest thing has been like remembering that there's more than one way, right? So Anna can attest to that there have been certain ones that I've been involved with when we go in and we've disagreed to certain points, right? But we've also, in the course of continuing to have these conversations, have come to a very good understanding of the kind of messages that we are going to speak on, especially if it's age appropriate. For instance, Anna is great at that. And she is definitely the one that would go to the schools because of that. So I just wanted to say it's the collaboration right there that I think is important, and listening to one another's concerns. And then I'm going to turn it over to Anna because I know she's got something to say on it.
Well, I just wanted to mention that really my amount of time in schools has been relatively limited, and basically in Reno County in general. So I always talk with whoever's requesting the class or presentation. I talk with them. What are our limits? What are you interested in? What's your what's your thoughts on this? And is there anything I specifically can't touch on? And so far, I think I've had a really good response. For the most part, I've talked about nicotine and tobacco because through the health department, that is my work plan right now. But like an approach I've had, and I feel like it has been well received, is kind of letting kids understand that when you use tobacco or nicotine, you're not rebelling against your societal norms. You're actually letting the tobacco companies use you for money. And so if you're feeling really rebellious, consider that they literally have said they have to get youth addicted because everyone else is going to die. So people, I mean, I've had kids that are like, why does Kansas let it be legal for tobacco? Because, blah, blah, blah. And it's like, we can't really get into talks about capitalism and prohibition, but although I would, but it's really just saying, this is why we have to look out for each other. This is why we have to be a community, because we're not always in control of things we have access to. And so I do think that a lot of the kids have been really, really interested in kind of hearing about big tobacco, and every single presentation I've given, none of them realized that, for one, tobacco companies, there's really only 3 that have all the products. And that the tobacco companies also are making e-cigs, because there's a lot of thought that like, oh, if I'm doing e-cigs, right, then I'm getting back at big tobacco that way, or big tobacco doesn't want you doing e-cigs so they can smoke cigarettes. So it's like, no, they're in on that market too. And so I think it could rather be the same with drugs. I mean, essentially, tobacco and drugs target who? Particularly marginalized groups, particularly people with mental health, particularly people with, low income, single parents, et cetera. And so combating this all together to make it better for everybody is the goal, not figuring out how to be comfortable in your own skin. That's the goal, not we're going to be mean and controlling and you need to not do this or you're bad, right? So I think that has gone well so far, the community kind of approach with the kids I've talked to so far.
Okay, well, we've had some conversation in the chat around test strips, and I think that's been answered, but if anybody else wants to chime in on that subject, or if we have any other questions in the last few minutes.
Well, I have one last question. I know we have 2 minutes, but what has been your position on the increased sale and public consumerism of substances on different types of public websites and apps like TikTok and things like that? I watched a presentation and was a bit surprised at the availability. Have you all spoken in any way publicly or made any type of position as it relates to that type of thing?
We have not discussed it, and definitely haven't necessarily taken a public stance on that either. Probably would, one of those things that we would discuss in that upcoming meeting, especially getting more input on that from people who are involved with our organization.
Okay, well, if there's nothing else, I think it's time to wrap up. Thank you, Jackie, Anna, and Seth so much. That was a fabulous presentation. And again, this session will be recorded, and in about an hour will be available to everybody. So thank you so much. Enjoy the rest of your day.